Okay. Thank you very much, everyone, for joining us today. Um, my name is JP Monroe, and I'm going to be the facilitator for this event. I'm a proud RPN working as a professional practice associate here at WeRPN, and today I'm honored to be the facilitator for the Easing the Swell Essential Insights for RPNs on Heart Failure. We would like to begin this session by acknowledging that WeRPN is located on the traditional lands of the Anishinaabeg peoples. With this, we respect the longstanding relationship that Indigenous people have had to this land and as the original caretakers of this land. We acknowledge historical and ongoing injustices that the First Nations, Inuit, and Métis peoples have endured in Canada, and we accept responsibility as a professional organization to contribute toward revealing and correcting misinformation, as well as renewing respectful relationships with Indigenous communities through our teaching, research, care provision, and community service. I would also like to acknowledge all of Ontario's registered practical nurses across the care continuum and would like to extend my heartfelt thank you to each and every one of you for all the work that you are doing to care for patients, residents, and clients as you continue to go above and beyond your commitment to care. Happy Nursing Week to you all. As a virtual attendee, you can watch the presenters live and engage throughout the presentation through the chat and the Q&A functions. Please let us know if you are viewing, where you are viewing from today. So if you just type in the chat where you're viewing from, we would love to see where we have attendees attending from across Ontario. If you have any technical issues and need assistance, please contact ppractice@werpn.com via email, or you can call 905-602-4664 extension 228, and Itzel will assist you. And you can also find this information that I will put into the chat. I'm just going to copy and paste here if it will let me. And I see in the chat we have many people. I see Thunder Bay, Bowmanville, Toronto, Palmerston, Big Tingon, Nishnabeg, St. Catharines, Muskoka, Trenton. That's fantastic. So here is the contact information if you need assistance with technical assistance. At the end of the presentation, we will be announcing the winner of this session's door prize. So don't log out right after the presentation. We will be having a prize that will be drawn. So please note you must be here at the end of the session to receive the prize, or we will redraw the names. I now have the honor of presenting our speaker for this session. Katie Fleming is a registered nurse and a nursing educator with over 13 years of experience specializing in cardiac and critical care. Throughout her career, she has focused on supporting nurses' professional development, promoting evidence-based practice, and fostering collaborative, high-quality patient care. Katie is passionate about creating positive learning environments and helping nurses grow in their roles. Brittany Vanderwall is an RPN who's dedicated with over 5 years of experience in healthcare. As a graduate from Seneca College, she has worked in both long-term care and hospital settings, providing compassionate, patient-centered care. Brittany believes nursing is a calling and is committed to supporting the physical, emotional, and mental well-being of those she cares for. She takes pride in collaborating with healthcare teams, advocating for her patients, and continually learning to grow in her practice. So Brittany and Katie, welcome, and thank you very much for presenting to us today. I will let you take it away.
Okay, thank you so much. So as JP said, my name is Katie, and I'm just going to pull our slides up. Just give me 1 second. Okay, is what everyone see my slides? I hope.
Yep, I think they look good.
Okay, perfect. Thank you. So Brittany and I are here today to talk to you a little bit about heart failure. And the presentation is called Easing the Swell because one of the most common things we think of when we think of patients with heart failure is that swelling, that edema that they get. But the ocean is a really good kind of metaphor for heart failure itself, because when we think about heart failure, it's a chronic illness that once someone has, they'll have for the rest of their lives. But what we see is that tide coming in and coming out, those acute exacerbations coming on, and then coming back to a baseline, but that water is always kind of there. So we're going to talk about how we can decrease those acute exacerbations, how we can intervene early, and how we can help our patients who are experiencing that overwhelming feelings that come along with heart failure and a heart failure diagnosis. Brittany and I were actually worked together in cardiac care at an acute care hospital. How do I change my slides? And although we work in acute care and in cardiac care, Brittany is going to talk to you about why you should care about heart failure.
Good morning, everybody. Hope everybody's doing well. I do apologize if I'm a little bit off the Richter. I just got off a night shift and I haven't slept yet. But basically, Katie and I, we do work together on the cardiac unit. We work alongside with RPNs, who I am, and Katie is an RN, or nurse educator. So basically, you should care. The bottom line is, whether you work in healthcare or not, any sector you work in, it's very prevalent along like many other people throughout Canada. Actually, I was reading the statistics for 2024. There's about 38.8 million people in Canada, and with that being said, with over 600,000 people have cases of heart failure in Canada. Statistically shown, the number one reason for adult hospitalization in Canada and the US is because of heart failure. It is quite expensive. $10 billion is spent annually on just the hospital costs for patients with heart failure. And with that being said, unfortunately, all good things come to an end. 50% of the patients with heart failure will die within the first 5 years of it. So it's a pretty significant number.
So no matter where you're working, you're probably taking care of heart failure patients, long-term care, palliative care, in the community and in hospital. It doesn't matter where you work, you're going to come across these patients. So what really is heart failure? In 1832, James Hope described backwards failure, as he called it, where he noticed that if the heart wasn't working, things tended to back up. The heart seemed to go backwards, and fluids would start to accumulate in places that they shouldn't be. We have a better understanding of heart failure. We know that there's lots of different types of heart failure, and heart failure has lots of different names it goes by and lots of different causes. The one thing about heart failure, though, is that the symptoms tend to all be really similar, and our treatments are limited, but we have some good treatments for certain types of heart failure, and there's things we can do for all of them. So some people talk about a right-sided heart failure versus a left-sided heart failure. Which side of the heart is starting to have the problems? However, you can definitely have heart failure on both sides of your heart, and we will see those changes systemically with both types of heart failure. The other names you might hear a lot are HFpEF and HFrEF. So I just want to go through that a little bit. So when we talk about HFpEF or HFrEF, if you see these for your patients, it stands for heart failure. HFpEF is heart failure with preserved ejection fraction. And what that means generally is that the heart doesn't want to fill as well. Maybe the space inside the heart is less available, like those empty little chambers have maybe filled with muscle, or that tissue has become incredibly stiff. So the heart is still pushing out greater than 50% of its blood. It's just that there's less blood in there to push out. Ejection fraction is something that people in cardiac care love to talk about. How much blood is coming out of the heart, specifically the left ventricle, at any given time. And for most of us, it's going to be greater than 50%, probably closer to greater than 60%. But people with heart failure can still have that ejection fraction, and maybe they just have that really, really stiff heart muscle. However, patients can also have something called heart failure with reduced ejection fraction, or you'll hear people call it HFrEF. And these people tend to have really, really dilated hearts, so their hearts have been stretched for whatever reason. They may have had a long-standing arrhythmia. They may have just had like that weakening of the heart muscle. And when we look at how much is coming out, it's not, the ventricle isn't fully emptying. Having said that, if you have left or right, HFrEF, and there's a couple of other names in there too, heart failure really just means that your heart isn't pumping effectively to meet the body's needs. So we know that our heart is the big pump, and it's sending everything around to make sure that oxygen goes out to all of our cells, that they have the energy and the nutrients that they need, that oxygen is moving, and that that blood isn't stagnant and clotting anywhere. So when we think about heart failure, it just means that our pump isn't moving as effectively as it should be. If you hear someone talk about left-sided heart failure, it means that the left side of the heart is the part that's backing up. So when we think of that backwards failure, so left-sided heart failure often leads to that pulmonary edema. And you can actually see someone in left-sided heart failure who doesn't have any peripheral edema. So they're sitting there really, really short of breath, and you're thinking, well, I know heart failure patients are always puffy, but you might not see that in these patients. Right-sided heart failure, when we think of that backwards pump, leads to that backup of fluid in the rest of the body, so systemically. And in my next slide, I'm going to talk to you a little bit about assessing patients with heart failure and some of the things we need to do to get past maybe our preconceived notions of heart failure. So there are some pretty common causes of heart failure, and those include high blood pressure. High blood pressure is like one of the #1 reasons someone will end up with heart failure. So this uncontrolled hypertension for your whole life. And we talk about hypertension being a bit of a silent killer because people don't know, they don't feel their hypertension necessarily. So you're walking around and you're like, well, the doctor told me to go on this medication for my blood pressure, but I don't feel any different when I'm on it or off it. So talking to patients about blood pressure and managing that blood pressure early on. So when we're looking at people working in primary care, talking about how can we manage these causes before they come to us. Coronary artery disease. So we know that if you have a heart attack, you're going to damage some of that tissue. And once tissue is damaged, it can be beyond repair. And damaged tissue doesn't move very well. And the heart not moving leads to some heart failure. The other thing is that our heart has valves in it, 4 valves. Depending on who you ask, some people feel some are a little bit more important than others, but really all of them serve a very strong purpose. And when they don't move properly, it makes the workload on the heart harder. And so anything that makes the heart have to work harder increases our risk of heart failure. So heart failure is called heart failure because really it's the heart that's struggling the most. But heart failure is associated with symptoms in all body systems. Our heart, despite being this tiny little organ in our chest, matters a lot to everybody. So when we talk about heart failure, we want to talk about assessing our patients in a really fulsome manner and looking past just what's their pulse and what's their blood pressure. So cardiovascular assessment is incredibly important, and I don't want to lead you astray. Heart rate and rhythm are incredibly important for the heart failure patient. We do try and keep those patients in a nice controlled heart rate. And an elevated heart rate can tell us, oh, maybe something's starting to happen. We want to keep our patients' blood pressures on the lower side because if we think about the heart being a pump, and you think that vascular system is what that pump is pushing against, so the amount of weight that it's having to push to get that blood out the door, the higher the blood pressure, the more the heart has to work. The more the heart has to work, the more oxygen it needs itself. So we want to watch for that. When you're listening to these patients, you're going to look for other signs of an underlying cause. So maybe you might hear a murmur in these patients, but you don't need to hear a heart murmur. You don't need to hear abnormal heart sounds for a patient to have heart failure. And then we're looking for that venous distension as well in their neck as a sign of maybe, oh, that fluid is starting to accumulate. We can also look for edema elsewhere in the body, but I'll talk about that. So when we think about the heart and we start backing up, the first thing I start to think about is my patient's lungs. And so that increased pressure from the heart backing up into the lungs is what allows the fluid to go into the alveolar spaces. So our lungs start to actually fill with fluid. What are you going to see? You're going to see someone who feels short of breath, who has crackles. However, you can have pulmonary edema without crackles. But crackles is a really, really common thing you're going to hear in your patient's lungs. You may see an abnormal pattern of breathing depending on what's going on with their breathing. Tachypnea is something that we really want to start to look at and intervene earlier. And then we want to talk to our patients about orthopnea, or can you sleep lying down? And paroxysmal nocturnal dyspnea, which is that shortness of breath while you're sleeping. Brittany's going to talk about that a little later on, but those are just some things to think about beyond just, oh, what are my patient's O2 sats? Because that matters, but let's do that fulsome assessment. Next, let's talk about the integumentary system. So we're looking for swelling. We're checking for pitting edema. And there is actually guidelines for what is pitting edema and how much, like what is level 1, 2, 3, and 4. And I didn't include that in this presentation. I kind of regret that right at this moment. But what we're looking for is how long does your fingerprint where you've checked for your edema stay, and how deep does it go? Because we want to make sure we're all grading edema on the same scale, so that when Brittany assesses her patient and she says, oh, Katie, this patient has 3+ edema, I can go in the next shift or the next time we see this patient, maybe you're out in the community and you see them a couple of days later, you can say, yeah, this patient actually now is at a 2, so I think this treatment plan that we're following is working, or, you know, I think we're at a 4 now and I'm actually starting to worry that perhaps this isn't great. What we're also looking for, though, is signs of decreased circulation. So looking at someone's skin can give you a really good idea of how well they're circulating. So patients may end up with this cooler skin because that heart isn't pumping well enough. They may end up looking a little bit pale. And if you're finding cyanosis, that's a sign that like things are really going poorly. But just looking at what is the temperature of their skin, what do they normally feel like? Because remember, this is a progressive illness, so your patient's baseline is going to change, but we want to intervene as early as we can. The GI system is something that, when we think about heart failure, can get forgotten really easily, but is incredibly important. So patients who have this, and I use the word patients because I'm really used to working in a very acute care hospital. And I know that's not the word that everyone uses for the people that they take care of. And so I apologize for that. But patients is what's going to slip out of my mouth most of the time. So patients who are experiencing heart failure, that backup of fluid can actually really readily go to the liver. So you can actually see patients who start to get elevated liver enzymes as a sign of a heart failure acute exacerbation, or pain in their liver, or their liver starts to get a little bit enlarged. And that's because of that fluid backup that's going to the liver. You can also develop ascites, so that fluid accumulating in the abdomen. And that's really important because as that fluid starts to accumulate, it can actually accumulate in the bowels as well. And when that happens, we may not absorb our medications as well as we normally would. It can lead to loss of appetite, nausea, vomiting, constipation, those sorts of things. And weight is so important with heart failure patients because we are watching for that fluid retention via weight, and Brittany's going to talk about that in a little bit too. And so we care a lot about their weight, but we also know that they're at a huge risk for losing their muscle mass, and they can become quite cachectic, so cardiac cachexia. So we're watching for fluid weight loss, but we also need to watch to make sure that our patients aren't losing too much muscle. They may not be able to eat as much. They may need to go to a higher calorie diet and some supplementation. When we're talking about GU or our urinary system, it's really important to note that these patients are going to end up on some forms of diuretics, right? Because we're going to move that fluid for them. So talking to their patients about their urine output and whether it's kind of where we want it to be, but also talking to them about lifestyle and how those diuretics are affecting them. So surprising number of people still think like, oh, I'll just take my diuretic in the morning and with dinner. And depending on when your dinner is, that might really affect your life and your ability to sleep. So we want to make sure that our patients are having a good quality of life while we treat their heart failure, because that's really what this is all about. So assessing patients for any signs that their renal system might be declining. So any changes in urine pattern, urine color, but also making sure that those diuretics are still working. I always say the heart and the kidneys are sisters. They're best friends. There's actually there's a type of heart failure called cardiorenal syndrome, where your kidneys and your heart both kind of hand in hand stop working, and when one starts going, the other starts going, and the two of them kind of play off of each other. And then the last thing is that patients who have heart failure are having this impaired oxygen exchange. They're having a hard time getting oxygen out to their muscles, and they may also end up with some exercise intolerance. So assessing your patient's ability to exercise, what they're doing, and how can we ensure that we keep that muscle that they have and make sure that they're able to maintain their quality of life. So that's kind of like remembering to do that really fulsome assessment, that we're not just assessing their heart, and that heart failure isn't just about the heart. Having said that, let's talk for a moment about the treatment guidelines. The treatment guidelines for HFrEF are really, really well done. For HFpEF, we just have less options. And the reason I want to talk to you about the guidelines is because A, we know that they work really well. But secondly, I find a lot of nurses and patients especially sometimes don't know why they're on the medications they're on. And the Canadian Cardiovascular Society and the Canadian Heart Failure Society got together and made these heart failure guidelines. And then they were like, well, this is a really long document, and we want people to really readily understand what's actually going on in this document. So they made this beautiful picture that I'm showing you now that talks about what we need to do for a patient in heart failure. So first thing, we need to deal with their comorbidity. So talking to them about all the other things. Diabetes is really common. So if you are working at a diabetes clinic, really making sure that they're able to manage their diabetes so that heart failure doesn't become exacerbated by it. They may need some PRN diuretics, and making sure that our patients understand those diuretics. But there's 4 main medications that all patients with heart failure with reduced ejection fraction should be on. They're called the foundational 4, the fantastic 4, it depends who you ask. And those 4 medications is where people start to get a little confused. So the first recommendation is an ACE inhibitor, an ARB, or an ARNI, which is a combination medication. So, and the only one we have right now is Entresto, and it is kind of like the golden bullet for heart failure. And we understand that if we can lower that blood pressure and we can get those kidneys in the place that we want them, their heart failure is going to get a little bit better. That one makes a lot of sense. We then talk about beta blockers, and when we talk about the heart, it seems like beta blockers are intrinsically there. So many patients are on beta blockers, and beta blockers are going to slow that heart rate down. They're going to allow for that good filling time. They're going to try and help keep our patients in a normal rhythm. Beta blockers seem to be well understood. MRAs, though, when I say that, people tend to get a little bit like, oh, I'm not sure if my patient's on an MRA. I don't really know what that is. And the easiest way for me to tell you is the most common one is spironolactone. So we're looking at our more potassium sparing diuretics, which are really lovely for patients to take at home, and they work really well. Brittany's going to talk to you a little bit about what that means for your patient in terms of diet in a little bit, but knowing that your patient is on a diuretic, even if they're not on Lasix, is so important. Because I have a good friend who I was talking to her about her father's heart failure, and she was like, he's not on a diuretic. And I was like, that's really surprising to me. But then when we started talking about it, he is. The last medication is the one where patients get a little concerned, and that's an SGLT2 inhibitor. And I'm not sure how many people have interacted with them. They're drugs that tend to end in Lozid is the suffix for these medications. And SGLT2 inhibitors were originally designed to be used for diabetes. They help using osmosis. They actually help bring sugar out of the body. But it also brings extra fluid because it changes how sodium is reabsorbed in the kidneys. So what we found out is this is a really, really good diuretic that has evidence for use in all types of heart failure. And as a little like happy note, if your patient also happens to have diabetes, it's going to work for that too. But even if your patient isn't diabetic, an SGLT2 inhibitor, when they're at home and not in an acute exacerbation, is a great medication. The reason I want to point this one out is because I've seen patients say to me, I'm not diabetic, and I looked up this med and it says that it's for diabetes. And I say, absolutely. But sometimes we use medications for more than one thing. And the story I always like to tell when I talk about that is the fact that Viagra is actually like that sort of medication. Viagra itself was originally designed for pulmonary hypertension. It's actually a cardiac medication that we realized had another use. So SGLT2 inhibitors, same kind of thing, medication made for one thing, and we found out there's a second use, and why not take advantage when it works so well. So talking to your patients about what to expect from that, and knowing that your patient isn't necessarily diabetic just because they're on an SGLT2, we really do have to look at that whole picture, because you might just have a heart failure patient on your hands. There's a lot more in-depth treatments when we talk about maybe putting an ICD or defibrillator in a patient, or cardiac resynchronization therapy. We're not going to talk about that in this presentation, so we're really talking about like the basics and what we need to get across, but remembering that we want to keep our patients' heart rates below 70 generally, and in sinus rhythm if possible, but that's not possible for all patients. We want to try to avoid hospitalization. We want to get these patients on goal therapy, and we want to intervene early anytime we see an increase in symptoms. The last thing that's on this list, and that's to the right side of the presentation, is non-pharmacological therapies, which is what we're going to talk about after this. And that's where nursing can really step in and educate our patients on how to take care of themselves with heart failure, and talking about advanced directives and goals of care. This is really an end-stage disease. Palliative care can and absolutely should be involved in your heart failure patients. I know that at my hospital, the palliative care doctors spend a lot of time on our units working with our heart failure patients to make sure that we know what our goals are. So we want to make sure that these people have the best quality of life for as long as they can, but making sure that what we're doing aligns with what they want. Okay, Brittany, I'm going to hand it over to you.
Thank you. You'll have to bear with me. I've lost all communication on my computer, so I'm staring at a blank screen right now. But with that being said, so the basic things that nurses can do, and on the cardiac floor, we love doing it at 6 a.m. in the morning when we have to wake our patients up, is basically assessing and checking daily weights. So obviously, with that being said, you want to do it first thing in the morning, right after you have emptied your bladder is usually ideally the best time. And obviously before anything goes in your mouth, food, water, anything extra. You really want to be able to weigh the patient the same way every single day, whether it's if a patient's bedbound, you can use the bed scale. Make sure you use the same amount of pillows or blankets, just so you're not getting an odd reading. If the patient's independent, make sure that they usually weigh them without their shoes on because that's extra weight added. So you want to really use the same kind of clothing that they've been since day one. When we send patients home, we usually give them like a little piece of paper where they can record their weight. So we try to educate our patients, giving them little resources to help them. Um, Ideally, you want to weigh your patient every day at the same time, or when you go home at the same time every day. It's a good idea to make a chart with all of your daily weights, whether you're inpatient or outpatient. It's really good to explain that to the patients as well. When you do a follow-up visit with your either cardiologist or your family doctor, I always advise them to write down their weights, bring it in. This way, the doctor can see, any trends. You always want to keep them informed, whether it's good or bad, because you never want to lie to your doctor. In generally speaking, if your weight does go up in like 2 pounds in a day or over the course of 1 week, 5 pounds, you're going to want to contact your doctor. They're going to have to go over, reassess everything just to ensure that nothing, is going the wrong way and everything is going to go the right way. Other than that, Katie, if you want to chime in on anything, just because, like I said, I have no screen to look at, so I'm winging it here.
That's okay. That's basically the goal, is making sure that patients understand that even on discharge, a daily weight is really important because of that early intervention. So if we're seeing 2 pounds in a day or 5 pounds in a week, it's a sign that maybe that heart is starting to have a little moment. And for some patients, they're going to have an algorithm they follow. So a PRN, maybe Lasix dose that they take, or they'll change the dose of their diuretic based off their weights, depending on who follows them and what heart failure clinic they're going to. But making sure that we're intervening early, and if they're seeing those changes, that they're contacting a healthcare provider, or if we're noticing those changes, that we're contacting their provider to make sure that we can start maybe intervening early and get that Lasix off, so we don't have a massive decline and really acute exacerbation. The next slide is about fluid restriction.
Yeah, so with fluid restrictions, again, on the cardiac unit, we love to get our patients mad at us for not giving them as much as they want. So it's definitely important to monitor the fluid intake. Obviously, as you guys know, too much water will and can reverse any of the medication, and obviously potentially worsen the heart failure condition that they're in. We like to monitor their salt intake as well. Usually with the practical guidelines, we do 1.5 to 2 liters per day for fluids. And then usually salt, unless told otherwise, or sodium is 2 grams a day. I know it's hard to monitor when you have hospital food, but we try our best. So they go into a cardiac diet. As you guys all know, seeing as you're all nurses, too much sodium can obviously cause your body to retain the fluid. Therefore, it's making your heart work a little bit harder to get rid of all that extra fluid. Extra sodium, like in the bloodstream, obviously pulls the water back into the vessels, and then therefore, causing your blood flowing through the vessels a little bit thicker, and then increasing your blood pressure and all that stuff, causing your heart to work a little bit harder. As far as like potassium, we obviously monitor potassium. Potassium's important, obviously, for heart function. Too much potassium is not good. Too little potassium is not good. And when you're on fluid restrictions and we're diuresing you, we closely monitor that. So on the cardiac floor, we have a lot of restrictions and protocols that we follow. We do a lot of potassium replacements on our unit. whether it's IV or by mouth. We just want to maintain that potassium as best as we can, along with the magnesium. As everybody knows, your heart is a muscle. With too little or too much potassium, it can cause it to create like a muscle spasm. I like to explain that to patients when they refuse to take the potassium because they're like giant horse pills. I simply explain to them that um, when you get cramps in your legs, they're muscles. Your muscle is a heart. If your heart cramps, then that's a big no-no. They tend to listen a little bit more when I explain it that way in layman's terms. And then, we usually crush it or give it to them whole, however they want to take it. But it's very important to monitor everything as far as intake, diet, all of that stuff. We do not endorse families to bring stuff in just for we don't want to reverse everything that we've tried to do for them. Katie, if you feel you want to chime in, please let me know.
One thing that's really important when we talk about potassium is remembering what diuretics our patients are on. So loop diuretics like Lasix is potassium wasting, and in those patients we have to monitor the potassium. That type of diuretic is used in an acute exacerbation. So that's what we see in hospitals. So if you are a hospital worker or someone taking care of someone at home, you may also see Lasix. And we're going to really want to monitor that patient's potassium because there's a risk of it getting too low. However, if your patient's just on GDMT, goal-directed medication therapy that I talked about earlier, they might not be on Lasix and they might be on something like a spironolactone, which is potassium sparing. And in that case, you want to talk to our patients about not taking too much potassium in their diet. So we have to think about what our patients are on. We also have to think about the fact that I've sipped my water like 3 times during this presentation, and I don't know if anyone's noticed. When Brittany said fluid restrictions are hard, fluid restrictions are hard. So talking to our patients about things that might ease that dry mouth or the symptoms of the fluid restriction is so important, because this is their day-to-day life. This is how it's going to be for the rest of time. And we want to avoid acute exacerbation. So things like instead of just drinking straight water all the time, talking to them about, hey, what if you like sucked on an ice chip, which once again, readily available in hospitals, might not be super available at their houses, but that can help ease that dry mouth. Sucking on like a hard candy, maybe a sugar-free candy, depending on your patient's background, can also help ease that dry mouth feeling. And then optimizing the fluids that they are taking in. So remembering that things like soup are a fluid, and too much sauce is a fluid. So many of the foods we eat are fluids. So when we talk about that, like 7 cups of fluid a day, we want to talk to them about like what 7 cups of fluid matter to you. Because for me, it's going to be water. I would much rather have a glass of water than have a bowl of soup. I will eat my foods as solids rather than liquids. So talking to patients about what are some things that are important to you? How do you want to get those 7 cups of fluid in, or 6 or 7 cups of fluid in a day, depending on what your patient's fluid restriction is? Because we have to find ways to work with our patient. This is their disease, their life. This is their process. It's not mine. And so what I want, what's best for them, and I want to do it in a way that they'll be happy with. So the next thing we're going to talk about are vital signs, because vital signs are vital. When we're in nursing, so many things, we always want to know about what their vitals are, depending on where you work. So patients with heart failure, it's really important to note that they are on medications to optimize their heart function. And knowing their baseline vitals is really, really important, because we want to avoid that tachycardia. Remember how I said their goal heart rate is usually less than 70 or around 70. So our patients are going to be on medications that lower their heart rate. So they might be on a beta blocker. Well, hopefully they're on a beta blocker as long as they can tolerate that. We also see some of the other not found like fantastic foundational for medications focus on heart rate and rhythm. So there's a medication like digoxin, which helps with contractility, so how well the heart squeezes, but it can also lower that heart rate. We also look at medications like ivabradine, which is a sinus node inhibitor, that literally its only goal in the world is just to lower that heart rate. What we also know is that the higher the blood pressure, the harder the heart has to work. So we're giving these people medications to make sure that their heart can work at its optimal amount, and then we're not trying too hard. And patients on optimal therapy may have a systolic blood pressure of less than 100, and that might be their normal. So that's not true for all patients. And that's not true if that's not what your patient is normally sitting at, or if your patient is symptomatic. So understanding those vital signs is really important. So if I have a patient with a systolic in the 90s who is on optimal therapy and I know has poor heart function, especially poor left ventricular function, if I were to raise their blood pressure, it actually means their heart has to work harder. And when the heart has to work harder, it'll fail more. And then they're going to A, have more symptoms, and B, actually might lower their blood pressure because their heart can't pump out. We need to work with our practitioners to make sure we understand what is an okay blood pressure for this patient. And when they want us to talk about changing those medications. So people outside cardiac care, outside of heart failure, might see a low blood pressure and think, I shouldn't give any of these cardiac medications. I know that these lower blood pressure, and I don't want to give any of them. Really understanding what those patients' optimal blood pressure is, where we want them to sit, and when do we want to hold those medications is so important, because just stopping all of their heart failure medications can be quite detrimental. Now, I am not saying that you should just give all your patients their medications no matter what their blood pressure is. Absolutely not. We need to work with our pharmacists and our physicians as well, nurse practitioners, whoever is kind of guiding this patient's care, to understand what the goal for this patient is. But it's definitely something to stop and think about. What is the goal? When should we be talking about holding those medications? And talking to our patients about what signs and symptoms are a sign of maybe a low blood pressure. So is my patient now dizzy, having difficulty standing up? Any of those signs and symptoms of a low blood pressure, then we need to start intervening. But knowing that your patient might have a lower blood pressure, and that's okay. 120/80 isn't necessarily the goal of these patients. We really want to avoid tachycardia. We really want to avoid too high or too low of a blood pressure. And so because we know these patients might have a below normal blood pressure, so less than 120/80 or 110/70, depending what guideline you go by, we want to make sure we're always looking for other signs of perfusion. So earlier we talked about what can I look for in my patient's skin to see if they're perfused. Are they cold and clammy and maybe diaphoretic? That's a little too far. We really want to get intervention at that point. But is my patient's temperature changing? What is their neurological status? Because as soon as we start to have those changes in perfusion, our brain can kind of let us know pretty quickly, because our patients might start to have those neurological changes. Now, do we want to catch it when it's maybe just their fingers that are hypoperfused? Absolutely. But understanding kind of where your patient always is. Heart failure, because it's this chronic condition, bringing in the patient and their family to say, what is this normally like for you, and what are you like now, to understand the changes that are happening. Your patient's baseline is here, but it's going to go like this over the course of their changes. So we really want to keep on top of where are we, what's an acute exacerbation, and what is kind of this decline that they're going to continue to have. Okay, so how can we help our patients? The most important thing is teaching them how to help themselves and how to know when something is starting to go wrong. So ask them to keep track of how their breathing is. If they say, my breathing is feeling different, you need to take that really, really seriously. if your patient says, hey, I'm just like sleeping more every day, it feels like, yesterday I used to be able to get up, shower, put, blow dry my hair, put on some makeup, and go down and make myself breakfast. But now I find that I kind of do my stuff in the bathroom and then I sit back down for a while. Those are signs that things are changing, that we might need to help. Anytime we have an increase in pillow use when they're sleeping. So remember I talked about earlier, I said orthopnea is something we have to monitor. How many pillows do you sleep with behind your head is such an important question. Because we can tell how well someone's doing by how many pillows they need to prop them up. So if someone's normally a 1 pillow sleeper and they're now at 3, that's a sign that we probably need to start intervening. We might need to give a change in diuretic. We might need to do some things to make them more comfortable. And as soon as they start telling you, I only sleep in my lazy boy, we know, okay, we're at a place where they're really going to need some help. The other thing to take into consideration is heart failure is not always an alone issue. COPD and heart failure can definitely live together. And so knowing that a lot of these things are very similar with COPD, and our patients who have dual diagnosis are going to struggle just a little bit more. But we want to make sure that we're always optimizing therapy. So understanding that their dosages might change, the medications that they're on might change. We might need to give them that acute loop diuretic. We might need to talk about Lasix. We might need to talk about changing other medications, or maybe they're dehydrated. What do they do on days where they're sick? Having those plans laid out for them so that they can help manage themselves. This is really one of those things that patients need to take accountability and really be involved in their care. And then talking to them about PND symptoms. So that nocturnal dyspnea, paroxysmal nocturnal dyspnea, where they're really waking up out of their sleep and feel like they can't breathe. It's very frightening for patients. It can be very frightening for patients. And so helping them understand, hey, this is a symptom of heart failure. And if it's happening, we want you to let us know so that we can change your medications and start to intervene. And we can do things like talking to them about their diets, which I think I have on the next slide. So sleep is incredibly important to our patients. We're going to do everything we can to help aid in that, talk to them about how they're sleeping, how they can more comfortably sleep. Diet, huge part of heart failure. We've talked about the fluid restriction. We've talked about the fact that they might have nausea, vomiting because of that swelling in their stomach and in their abdomen. And so what can we do? We can go with high calorie beverages. We can go with high calorie meals to try and get them that energy. Heart failure is really taxing. It's your heart running a marathon. And it's running that marathon uphill because yes, your heart beats every day all the time, but the rest of us are running on a flat road. And these patients are running uphill all the time. If your patient starts noticing a change in appetite, that can be a sign that their heart failure is getting worse. Or a sign that we need to talk to them about maybe changing what they're eating. We want to talk to them a lot about their bowel movements. Diarrhea can be a side effect of heart failure. Your patient can also become constipated because remember, we are A, giving them diuretics, and B, that swelling of the bowels that can happen can change how things move through. Now, we have this awesome thing called an osmotic stool softener, laxative, osmotic laxatives. So things like Laxative, PEG, they actually help draw that extra fluid out. So decreasing that edema of the bowel while also helping your patient have a bowel movement. So when we're thinking about helping our patients with that, so when we think about bowel movements, I want you to think osmotic rather than stimulant laxatives, because we can kill 2 birds with 1 stone here. We can help decrease that edema, which is going to help them anyways, while also helping them have those bowel movements. Bring in your friends when it comes to heart failure. So the number one thing I'm going to say is if your patients have access to a cardiac rehab program, we should always be encouraging patients to go to cardiac rehab to help with that exercise, build up that exercise tolerance, knowing that, running a marathon is probably not where we're going, but making sure that they have a good quality of life and are able to do the things around their house that they want to do. Patients can benefit from occupational and physical therapy with heart failure. Yes, it's a chronic condition. Yes, it's progressive, but that doesn't mean we can't help them stay where they are and maintain that quality of life for as long as possible. I've kind of mentioned before that palliative care, let's bring those friends in. Remembering that palliative care does not mean they're in the imminent end of life area. It just means we're going to talk about medical treatment. Kind of think of it as like a crisscross where this is your palliative care, and they're going to do just a little bit at the beginning. And as that patient's journey changes and their goals change, they might take over. And our cardiac care or our medical care is going to start really strong. And then we might get to a place where our patients become palliative. So bringing palliative care in, making sure people are supported to have end of life discussions, and making sure we're offering good symptom management. The last thing I want to talk about is patients. This is a really hard diagnosis on patients, but it's also incredibly difficult on families. Patients who have heart failure will inevitably lose their ability to do certain tasks, and they will become dependent on family, friends, those people around them to do those things. As your shortness of breath increases, as your heart continues to fail, you're going to need more help, you're going to need more caregiving. And it is really hard to watch someone decline like that. So families need to always be assessed, making sure that the families have the support they need, bringing in community supports as possible, talking to them about having PSW care come into the home to help, having OT and PT come into the home to help, having all of our interdisciplinary team be coming to help, and making sure that our families have the support they need. Social work is incredibly important as well. So make sure you bring in your friends. Nursing is an incredibly important part. It's one of the biggest drivers to quality of life when it comes to palliative or to heart failure, but we can't do it alone. And we will make sure that everyone that we have available to us is involved. So the big takeaways for heart failure. Heart failure is a progressive disease with acute exacerbation. So your patients will go maybe to the hospital and come and hang out with Brittany and I, or with you if you work in a hospital. And we're going to make sure that we're optimized on those therapies. Remembering that GDMT, those 4 medications that I talked about, are not necessarily used the same way in hospital. They're for the day-to-day living and not the acute exacerbation. But understanding that every time your patient has an acute exacerbation, their quality of life is not going to go right back to where it was. So it is progressive. They are going to have that decline, but we want them to have that decline as slowly as possible. So as your patient's baseline slowly lowers, we're going to monitor closely for any signs of an acute exacerbation and try and intervene early. We're going to talk about symptom management for the patient and what that means to them, and talk to them about what are your goals? How can we make the things we know are going to help work in your lifestyle? Intervene early, make sure that the power is in the patient's hands to take care of this illness, and make sure that your caregivers are getting the attention that they need, because caregiver burnout is a huge risk. Those are my big takeaways. Brittany, is there anything you want to add?
It's funny you say that. We actually had a patient last night while I was working. His wife ended up going to the ED because she was just so exhausted from caregiving that she was experiencing chest pain. Turns out she was okay, so that's good. But I think it was definitely caregiver burnout is a huge factor that we need to consider. In Canada, we definitely have a lot of resources that will help with people that have people at home that need the extra support. So make sure you reach out to whomever your charge nurse, your doctors, anybody that can really help you get that extra support, because I feel like that's probably one of the biggest things. But yeah.
Okay, so we're happy to take questions at this point.
That is great. I am just trying to, oh, there we go. Had to turn my camera on and it was lagging a bit. I have a few questions throughout the presentation that I will ask now. Let me just share my slide here. And, oops, apologies. Okay, we have some time for questions. So the first question I have is, how can one manage fluid restriction recommendations in home and community care? They say that I find my clients take it more seriously when they're in the hospital.
Yeah, everyone takes everything more seriously in the hospital. The thing I can compare it to best is in hospital, we always offer nicotine replacement therapy, and we say like, hey, we really want to help you quit smoking. Let us help you. And everyone's like, don't worry, I can totally do it cold turkey. And in hospital, they don't smoke. And then when I see them the next time, they're totally smoking again, because you have that shocking moment in the hospital. And in hospital, we control your fluid restriction. So the most important thing is putting that back into the patient's hands. And we're trying to do it even in the hospital by having patients record how much they're drinking. I think the number one thing is though is making people feel empowered, because if you are thirsty, you will drink. It's the natural progression. So kind of like I talked about, that really importance of talking to them about, hey, this is how much water you get a day. Maybe put that cups on, like those cups on your fridge or your whiteboard. There's also a lot of good heart failure apps available. We have one we recommend through our heart failure clinic to help patients track, because water can get away from you. So helping patients with a tracking app, but then talking to them about all the sources of their fluid and helping them choose which ones are important to them. So it's really important to me that I drink water. I would prefer to maybe have like a popsicle that I can have over the course of a period of time to keep my mouth nice and cool. And then talking to them about those thirst mitigating strategies. So things like having like a little candy to suck on. Some patients just enjoy having a little bit of lemon, because that really like increases the salivary glands and stops that feeling of dry mouth. Can make a big difference. Those are my biggest things that I recommend to my patients. Brittany, do you have anything else?
Me personally, I'm a visual person. So what I would recommend for other people is putting it right in front of them, putting it in their face, putting the numbers in their face. Sometimes it's like a tough love kind of business. It's good to get your family involved. That way you have the support as well. So, if you have a nagging wife or an annoying husband, that will just give them another reason to be those things towards you. But it's really good to put the numbers in front of you, visually see everything. So if you're only allowed to have seven cups of water, you put 7 cups out. And at the end of the day, you should have none left, but you should have no extra. I also like to write everything down. I'm very much a note taker. I know these are just strategies that work for me, but I know a few other people that like to write everything down and see it in black and white. Like you mentioned, there's a couple apps that I've seen that are very helpful. Yeah, just basically visualizing everything definitely works for me. So that might be an option as well.
That's great. I'm definitely going to use some of those in my practice.
Yeah.
That's what one of the things that I find difficult is in the hospital when you're really busy and you're trying to keep track of everybody's ins and outs. So it's good to have that patient involvement for sure. Another question here. At end stage heart failure, how can you help clients to better manage leg pain and cramping at night?
You know what? I don't have a good answer for that one. I should, and I don't. And I will reach out to my heart failure clinic and see what they are recommending to their patients. You do want to make sure that your patient's electrolytes are balanced, and massage can help. But I don't have a great answer for you on that one. But I'm happy to reach out to my heart failure clinic and get back.
Great.
Sorry.
No
I know
problem.
like some therapeutic. I know with some people that have leg cramps, they use like a warming blanket on the muscle. I don't know if that actually works or not, but I've been told it does. Or even like cold compress just to keep those muscles intact. I don't know if that's true or if it's just, something that they say, but that could be an option as well.
Okay. Another question here. Is it typical in end stage heart failure where the vitals machines can't catch a heart rate or a blood pressure?
So it depends how end stage the patient is. But understanding that your patient may have a really low blood pressure, but they also just might have really impaired circulation. So there's a lot of things to take into consideration there. Does your patient also have some peripheral vascular disease that's going to make it more difficult? Does your patient have an irregular heart rhythm that's going to make it more difficult? So understanding this patient may have a really weak pulse. And it might be irregular because AFib is pretty well associated with heart failure. AFib doesn't mean heart failure doesn't mean AFib, but they definitely have an association. Lots of vital signs machines are unable to tolerate the two mixed together. And just remembering what else is going on in my patient. When I look at them, do they look like they're perfusing the place where I'm trying to get their blood pressure from? So, if I see signs of impaired circulation, it might be possible that the vital signs machines can't pick up. And if my patient is truly at end of life care, then we might not be able to get vital signs. But if you're at a place where you think you should be able to get vital signs and you can't get vital signs, one of my biggest recommendations is to move on from a vital signs machine. Check that pulse manually. Feel it in the wrist, feel it in the neck if you can't get it there. Find where your pulse is, because that gives us an idea of where their circulation is kind of at. The other thing you can do is take a manual blood pressure. Anytime you have a patient, and now I'm going to talk a little off topic, but anytime you have a patient with an irregular heart rhythm, so something like AFib, and I don't need your patient to be on a cardiac monitor for you to know that. When you palpate that pulse, you can tell if it's regular or irregular. Our automated machines struggle with that, right? They're listening for those sounds and they say, okay, this is how often the heart is beating, so I should expect one. And sometimes when you have a patient with a really irregular heart rate, it just can't tolerate that in order to read a blood pressure. And you'll get like one really high blood pressure, one really low blood pressure. Your blood pressures aren't going to make sense. Really sit there with a stethoscope and a blood pressure cuff and listen to that patient's blood pressure. So important that we adapt to tech, like that we bring in technology, and technology makes our jobs easier, but it's not perfect. And so, one, is it the machine failing and can we do it by hand? And then secondly, do I have signs that maybe where I'm checking, I'm having impaired perfusion? And then thirdly, like understanding that things are going to be weaker. And at the end of life, at the actual end of life, it's always important to have a conversation about what are the goals of vital signs. So I think you're probably talking about people who are still enjoying their life or still in a place where we're actively treating, but just remembering that there is going to also become a point in time where what is the point of those vital signs? I hope that answers your question.
That's great.
Manual is great. Everyone should still be able to do a manual blood pressure.
Okay, thank you very much. I think those are some good strategies, and I think it was a very informative presentation. So thank you again, Katie and Brittany. We just hope